This is a huge topic, so I'll try and do it justice in 8 minutes. Uni or total? What are we going to say to our patients? Well, of course, we would look for an evidence-based approach. We need to look at big data sets, and there are none bigger than registry data. So I'm going to look at registries. Now, if you look at registries, the problem is if you compare unis and totals, every registry show there is a significantly higher failure rate with unis compared to totals. Registries conclude that we should not be doing unis. But the big question is, should we stop? Is this an accurate reflection of what's happening? So this is just a Trent register showing different numbers of total knees here. There's one which is doing brilliantly. Out to 20 years, we should all be using it. But look what it is. It's a Sheehan hinge. And the only reason it survives is because you cannot revise. Virtually all of them are loose and infected, but the type of revision in those days was difficult. So what about this? This is a patient who, two different types of patients, pain worse than preoperatively, no mechanical symptoms. What about the threshold? I would suggest that many surgeons would convert that to a total. How many surgeons would convert that? Actually, patients rather like the fact that there may well be a solution. We don't tell them that painful totals rarely have a solution. So what about registry data looking at unis and totals? Well, in New Zealand, they collect 6 months Oxford scores. You can see unis are doing better than totals, but that's not a randomized study. If you divide them up into poor, fair, excellent, and good, you can see unis have more excellence than totals, and they have fewer poors. The difference in revision rate is not because of poor results. But look at this. If you look at the worst 6 months Oxford score, you would imagine that if the patients are unhappy at 6 months after surgery, there would be a higher 2-year revision rate. And in fact, there is. If you look at the score less than 20 after surgery, so pretty unhappy, you can see that there is a 30 times higher revision rate than if the patients are happy. Now, if you look at this, it looks as though they're fairly similar. But what you have to do is you have to have them on the same axis. And you can see that with a worse result post-operatively than preoperatively, 60% of unis are revised and only 10% of totals are revised. The difference in revision rate is due to different thresholds, not due to poor results. A higher revision rate is not a reason to stop unis. Should we be doing more? Well, look at this. Here's 2 different types of graphs on the registry. The top one, totals doing better than unis. The bottom one, unis doing better than totals. They look almost exactly the same, but there's different outcomes. The top one's revision, the bottom one's death. So unis obviously are done in younger, more active patients, so a lower death rate. But of course, if they're young and active, there's going to be a higher revision rate. The solution, we can't use raw data. What we have to do is match the data. And I won't go into this in any detail, but a fellow of ours matched NJR data comparing unis and totals, and he looked at all sorts of different confounding variables to get a perfect balance. So what do we find? Well, again, we find that if you compare unis and totals, matched data, there are more excellent unis than totals, and there are fewer poor. We know that. In fact, there's a 60% chance of a higher excellent score with a uni than a total, and that's the same whether you look at excellent, you look at EQ5D, any number of different things. What about complications? Well, the length of stay is significantly less. The readmission is half. Intraoperative complications, transfusion, much, much less. Look at these ones down here, DVT, infection, CVA, MI, much less with unis compared to totals. And they may possibly have long-term effects. So let's look at mortality. Matching, this is looking at the NJR data and the hospital episode statistics, so that's readmission. And you can see if you look at unis and totals, at 30 days the mortality ratio is about a fifth, and at 90 days it's a half if you use a uni. Even out to 8 years it's less, 13% less at 8 years. Unis we know are much safer operation than a total. If you did 100 unis in the NHS in the UK instead of totals, there would be 1 life saved with 3 extra revisions. Now, a total knee is a safe operation. We're not suggesting otherwise. If patients have severe arthritis, they are unfit. If you do a total, their mortality decreases. If they happen to be suitable for a uni, their mortality is even less. So how can we address the high revision rate? We need to understand it. I mean, revision is an unsatisfactory endpoint. A fusion or amputation is not deemed a failure. An MUA is common with total knee. It usually predicates a poor outcome, but it's not a failure. A reoperation is a better outcome measure. So let's look at surgeon numbers per year. And most surgeons do very few numbers of unis. In the UK, the most common number of unis per surgeon per year is 1. The second most common is 2. The mean is 5.4. Look at the mean and failure rate. If you're doing 5.4 unis a year, you have a 2.5% failure per year, 25% failure at 10 years. It's understandable. If you don't do much of something, you're not going to do it particularly well. Now, we previously recommended a threshold of about 1 a month, but surgeons can't increase their practice. So this is the only other important slide I have. This looks at the usage, that is the number of unis per surgeon in the UK per year compared to their totals, and it equates with the revision rate. So this surgeon does no unis, he does all totals. These surgeons are crazy, they do many unis and very few totals. Now you would expect the more unis and the fewer totals you do in your practice, the higher your failure rate. But look at it, it's counterintuitive. It's completely the opposite. If you're doing few unis, less than 20%, look at your failure rate. It's much, much higher. So the really important take-home message is if you want to do unis, you need to be doing 20%. You need to get that magic number. As you do more, the failure rate drops down. And in fact, with the mobile bearing, you can go out to 50%. So the optimal usage is somewhere between 20 and 50%. The fixed, it's somewhere around about 20%. So if you look at matching unis and totals and the survivorship out to 8 years, you can see you've got about 40% higher failure rate with unis compared to totals. And that's using revision rate with optimal usage. If you look at the reoperation rate with optimal usage, the difference disappears. So in conclusion, what can we say from these huge data sets? Well, if you want to get all the advantages of unis, if you want your patients to be happy and come back and refer a lot of their colleagues, then you need to aim for a magic 20%. If you're doing it less than that, you may do well, but you may not do well. What can we glean from the registry data? Well, the registry data amply shows that in a discussion with your patients, you can say to your patients that the largest data sets in the world show that if you compare unis and totals, the clinical outcome for unis will result in more excellent results with less poor. There will be a rapid recovery, so a shorter inpatient stay with unis compared to totals, and they're cheaper. The complications are fewer and less severe. The death rate is lower, both in the short and the long term, and the reoperation rate up to 8 years is similar if you're using a usage more than 20%. And when you explain it in terms like that, you won't have any trouble at all in getting your patients to do unis. Registry data amply supports that we should be doing more unis. Thank you very much.